Chapter 29, Care of Patients with Disorders of the Lower GI System. Lesson 27.1, Care of Patients with Disorders of the Lower GI System Theory Objectives. Discuss the characteristics of IBS, explain how diverticulitis occurs, identify the etiology and signs and symptoms of a strangulated hernia, illustrate how the two types of intestinal obstruction occur and the symptoms, describe the pathophysiology, methods of diagnosis, and treatment for ulcerative colitis and Crohn's disease. Differentiate the signs and symptoms of appendicitis from those of peritonitis. Plan nursing interventions for the patient having surgery of the lower intestine and rectum. Discuss ways to help the patient psychologically adjust to having an ostomy. Compare the characteristics of hemorrhoids, pilonidal sinus, and anorectal fistula. Clinical practice objectives. Choose nursing interventions for the patient with inflammatory bowel disease. Assess for the signs and symptoms of appendicitis. Identify types of patients who are at risk for peritonitis. Create a teaching plan for the prevention of colorectal cancer. Write a nursing care plan for the patient with cancer of the colon and intestinal obstruction. Evaluate a nursing care plan for a patient undergoing colostomy, considering the type of stoma and the effluent it produces, and observe the equipment and procedure for changing an ostomy appliance. Of course, when we're looking at the word assessment, we can substitute it for evaluate. And writing a nursing care plan, let's revise a nursing care plan to stay within the scope of the PN. Diarrhea or constipation. The etiology and pathophys of diarrhea: frequent loose or watery stools caused by one of several different disorders or disease processes, most commonly. Constipation, potentially infrequent or difficult to pass stools, often caused by decreased fluid intake, medication side effects, or immobility. But constipation can also be a symptom of serious condition. What do? These patients need to have an assessment, including a history and physical. We can give them bulk forming agents. So our bulk forming agents are medicines like Sutracil or Metamucil, psyllium husks, okay? And they're going to act like fiber, absorb water in the bowel, and move that stool through faster, okay? We need to make sure our patients are drinking lots of water with bulk forming agents so that they don't create an obstruction. We can also give antidiarrheals for diarrhea. Antidiarrheals are Lomotil and Imodium, okay? Even Kaopectate or Pepto-Bismol. Antidiarrheals decrease how fast the stool moves through the GI system. It also decreases the secretions, decreases fluid in the stool. It binds up water, coats the mucosa, and absorbs toxins, okay? We need to make sure that this is effective. It should be effective within 48 hours. Make sure that these patients are not constipated or don't become constipated, because there is such thing as too much of a good thing. We need to be careful with patients that have an enlarged prostate, because this can cause urinary retention for them. And Pepto-Bismol can make their stool black, so we need to let them know. Medication can also cause dry mouth. They're not supposed to take any more than we order, or that is ordered for them, because it is toxic. Antidiarrheals can be toxic if given in large amounts. And then Lomotil is a medication that can affect a person's ability to be awake and with good response. So we want them, if they're using machinery or driving a car, to know how that Lomotil is going to affect them before they, decide to use machinery or drive a car. Okay, if their diarrhea does not go away after giving them antidiarrheals after 2 days, we need to contact the doctor. Antispasmodics are also prescribed, as are antidepressants, anticholinergics, and sedatives, and mild pain medicines. They need to eat a diet high in fiber, regardless of what's going on. They need to avoid gas-forming foods, onions, potatoes, cucumbers, coffee, tea, carbonated beverages, and alcohol. And if they're lactose intolerant, they need to avoid milk and other dairy products. We could encourage them to wear loose clothing so that they can be more comfortable. IBS. IBS is a functional disorder of GI motility. There is an abnormal function due to hypersensitivity of the bowel wall. People that have IBS typically have family members that also have IBS. There's a predisposition. And there may be foods they eat that trigger the IBS, whether it be gluten or dairy products or spicy fatty foods. usually these people have a trigger food. There is alteration in bowel elimination. They are either extremely constipated or they have lots of diarrhea or maybe a back and forth between the two. They have abdominal pain and bloating. They do not have Crohn's disease, ulcerative colitis, any kind of detectable organic disease. We've already ruled it out. They may not have um, a whole lot of mucus in the stool, but typically we do see some. It's called mucorrhea. They have abdominal bloating, and all of those symptoms are typically relieved by going to the bathroom. Okay. How do we diagnose irritable bowel? Well, first we get a H&P, an assessment. Then we rule out all other bowel diseases to make sure that nothing related to Crohn's disease or ulcerative colitis is present in these patients. That way we can call it IBS. We would not do any further diagnostic testing like imaging or lab work or anything like that unless additional imaging, that is, there are alarm features like extreme weight loss, iron deficiency anemia, or a family history of Crohn's or ulcerative colitis. Treatment and nursing management of IBS. Well, we manage the symptoms. We can give them the same medications we give for diarrhea and constipation, bulk forming agents, antidiarrheals, antispasmodics, antidepressants, anticholinergics, sedatives, mild pain medicines to relieve discomfort. We can put them on a high fiber diet. We need to explain to them about the process, explain to them the pathophysiology of their condition. We need to reassure them that the side effect or the symptoms that they're experiencing are normal for the condition, and encourage them to follow the treatment plan so that they can have relief of symptoms. There are also complementary and alternative therapies that we can suggest. Peppermint oil is one of them. It can provide some temporary relief of abdominal pain if the patient has IBS, but we do not want anybody with GERD or anybody, especially if they're taking like acid reducing meds, to take peppermint oil as well, because it can make the heartburn worse. And then we want them to remove gluten containing foods from diet or whatever their trigger food is. We know that gluten containing foods are possibly a trigger for IBS. Diverticula. So I jumped a page. Diverticula. They are small blind pouches that result from a protrusion of the mucous membranes in the intestines. Okay. Chronic constipation is characteristic of this. Chronic constipation is characteristic of this in that it causes it. If the person is chronically constipated, they have large volumes of stool in their intestines and it's causing those outpouchings. Obesity. If they are overweight, they're more likely to develop diverticula. What about low fiber diet? Yes, they don't have the appropriate stool. It's just not moving through like it's supposed to. They may develop diverticula. Diverticulitis is when the diverticula or the diverticulosis becomes inflamed or infected. This happens in about 20% of cases in diverticulosis. They do end up becoming a diverticulitis. Now, diverticulosis may be asymptomatic. They may have symptoms when it turns into diverticulitis, like they'll have rectal bleeding, diarrhea, constipation, left lower abdominal pain, nausea and vomiting, and the works. How do we treat it? High fiber diet, increased fluids, bulk laxatives, stool softeners. If the diverticulitis is uncomplicated, okay, so we don't have a perforation, clear liquids for 2 to 3 days with oral antibiotics to get rid of the infection or inflammation inside the diverticula. If it's complicated, it's starting to perf, or it's actively bleeding a lot, we can give them parenteral antibiotics with IV hydration, put them on nothing by mouth status for 2 to 3 days, and give them pain meds. Now, if you've got a true perf, so you've busted open, you're hemorrhaging inside, you've got the stiff board-like abdomen, or if there are recurrent episodes of diverticulitis, no matter what we do, we can't kick it, it keeps happening. Or we've somehow got some of that infectious material outside of the intestines and now it's inside of the peritoneum and you've got a peritonitis that may result in sepsis. That's when we're going to go in. We're going to do a washout. We're going to stitch you up, do a resection if necessary, some kind of surgical intervention. Intestinal obstruction. So there are mechanical obstructions and non-mechanical obstructions. Your mechanical obstructions are your volvulus, your intussusception, barium impaction, foreign bodies. You put something in there that shouldn't be in there one way or another. Or adhesions where the intestines are actually adhered together by scar tissue. A volvulus is the twisting of the bowel on itself. Intussusception is the telescoping of bowel, where one part of bowel goes into another, and barium impaction is just that. Non-mechanical obstruction, paralytic ileus. This person had a surgery, received anesthesia, had something else going on that caused their bowels not to want to move. Peristalsis has ceased. Okay, so we have to get their bowel moving again. Infection can cause an obstruction. Hypokalemia can also cause an obstruction. Poor intestinal perfusion can cause an obstruction. Because the tissue is going to be ischemic, peristalsis is not going to be doing what it's supposed to be doing, right? It's not going to be moving that stool along. Medication side effects like narcotics can cause people to be blocked up. And kidney disease all can impact the effect of peristalsis and therefore cause an obstruction. Signs and symptoms. Usually upper intestinal tract obstructions cause sharp, brief pains in the upper abdomen. They may vomit, they may be dehydrated, they may have abdominal distension. In the colon, they're going to have abdominal distension, vomiting, fecal odor, material. Yuck, it's gross. What can we do? We can decompress with an NG, we can do surgery, we can either do surgery to remove the blockage or do a resection. And we can also, as nurses, place these patients in a Fowler position, monitor their fluid and electrolytes, measure the size of their belly, and control their pain. Abdominal and inguinal hernias. Hernias are a defect in the muscular wall, and if they're in the abdomen, the muscular wall in the abdomen. Reducible hernias can go back where they came from. Irreducible hernias cannot go back. So if they cannot go back, they're called incarcerated hernias. Think about somebody going to jail. They're stuck in jail. They're not coming home, but they're not dead. They're just in jail, right? And a strangulated hernia is an irreducible hernia, so it won't go back where it came from. It's incarcerated, so it can't get out. But not only can't go out, think about the word strangulated. It is dying. It's not getting oxygen. So that can cause bowel necrosis, very dangerous, or tissue necrosis if it's fatty tissue in the hernia instead of bowel. Indirect hernias, direct hernias has to do with the location. That's not something we're going to really think about with this module. So I'm just going to put it on there. If you want to review it in your own time, you're more than welcome. Most common areas for hernias, weak areas in the abdominal wall, like the umbilicus, or in the inguinal ring or the femoral canal, okay? We'll see a lump, maybe some local swelling. When they lay down, it may go away because it is reducing, or because everything else kind of settles down around it. If they're lifting, coughing, or doing strenuous activities, sometimes they'll present. They will be irreducible hernias potentially that pop out during these kind of activities, and they can be uncomfortable, especially if they're incarcerated or strangulated. So here's an image. You've got the umbilical hernia up top near the umbilicus. You have a large direct inguinal hernia and a large indirect inguinal hernia. And both of those present in the groin area, just one's a little higher. The femoral hernia and the femoral canal. Sorry. Okay, treatment. What are we going to do? We're going to get rid of the hernia. Okay, that's our number one thing, surgical intervention. Let's get rid of the hernia. Let's reduce it. They'll go in, they'll push back what they can, or do a little excision of fatty tissue or whatever bowel's looping through. If they need to, they'll stitch it back up. Maybe they'll put in some mesh to help reinforce it, but regardless, they will fix the hernia. As nurses, we help control pain. We tell the patient how to prevent this from happening again. And we educate the patient on no heavy lifting, no pulling, no pushing, no straining during the recovery period. Bowel ischemia. Bowel ischemia is caused by insufficient blood supply to the bowel. It can be caused by a clot, either an emboli or thrombosis, the narrowing or occlusion of vessels, or bowel obstruction, even hypovolemic shock, so they don't have enough blood to get around. It may also be caused by chronic mesenteric ischemia, but that's extremely rare. We don't see that as often. These patients will have a sudden onset of abdominal pain, nausea, vomiting, diarrhea, abdominal cramps, minimal or absent bowel sounds, and their white blood cell count will be bumped. We can do a CT or an MRI, so magnetic resonance angiography, to look at what's going on with the bowel. Treatment. NPO, drop an NG. Why do we drop an NG? We drop an NG to decompress, and also to help us with suctioning secretions, etc. Smooth muscle relaxant therapies, thrombolytic therapies. If there's a thrombus, what do we give? Heparin. We're going to hydrate these folks. We could do an XLAP to see what's going on. That's where we We explore the abdomen during a laparoscopic surgery, or we can do a resection if there's necrosis and part of the bowel has truly begun to die and cause issues. Ulcerative colitis versus Crohn's disease. Well, both are inflammation of the mucosal lining of the intestinal tract. They cause ulcerations, edemas, bleeding, fluid and electrolyte loss, etc. Both patients may experience attacks of diarrhea with blood or mucus in the stool, abdominal pain with cramping, malaise, fever, and weight loss. Both patients can have exacerbations due to physical or emotional stress. But excuse me, and the umbrella is inflammatory bowel disease. Both ulcerative colitis and Crohn's disease are inflammatory bowel disease. We will diagnose both of these diseases or inflammatory bowel disease by doing a colonoscopy, flexible sigmoidoscopy to look at the sigmoid colon, mucosal biopsy, barium enema, or stool analysis. Here is the comparison. First of all, the area affected is going to be different because Crohn's disease is typically just in defined areas. So there will be skip involvements where a portion of the intestine is infected, then the next portion isn't, then the next portion is, and the next portion isn't. It can affect both the small and large intestine. Characteristics of Crohn's disease. These patients actually have autoimmune involvement, typically. Crohn's disease, if we look at the actual intestinal lining, we will see cobblestone appearance of the lining, okay? So whereas with ulcerative colitis, we'll see ulcers, just like it makes it sound like, right? Um, so signs and symptoms are what we talked about before. Complications, both can cause perforation, both can cause malnutrition, malabsorption, both can cause diarrhea or even constipation, technically. Lots of issues. Now, with ulcerative colitis, we do develop those pseudopolyps, as shown in the picture. Okay. Audience response question. I'm going to read this question, let you formulate your answer, and then I will tell you the correct answer. The recommended diet for patients with inflammatory bowel disease includes a combination of what? Low fat, high fiber, high protein, low calorie, or avoiding lactose. Okay, I'm going to show you the answer. Low fat, high protein, lactose avoidance. Okay, that's when we want people with inflammatory bowel disease to eat. Ulcerative colitis or Crohn's disease. Treatment varies according to the severity. How bad is it? How chronic is it? Is it all the time, or is it pretty rare that you have an exacerbation? Usually, we just manage the symptoms. We put them on a low fat, low fiber, high protein diet. We do small, frequent meals. We avoid lactose. We do corticosteroids, fluid replacement, or blood transfusions as needed. That's where we start to get a little bit more um, uh, involved with our treatment. We may even have to do a resection if it's really bad. Okay, here is an audience response question, the second one that I have in this slide. What statements regarding Crohn's disease would be considered true? It affects the full thickness of the small intestine. It manifests as bloody diarrhea with abdominal cramping. There is cobblestone appearance on radiographs. Pseudopolyps are found in the affected segments, or there is a greater risk for colon cancer. I will give you just a second to compose your answer. And the correct answer is there's a cobblestone appearance and it affects the full thickness of the small intestine. Now, we talked about blood in the stool. That does happen with Crohn's disease, but it's more indicative of the ulcerative colitis. That's where you're going to have, you think ulcers, they're going to be actively bleeding. So that's where you're going to have lots of bloody diarrhea. Now, pseudopolyps are found in ulcerative colitis as well. And ulcerative colitis is the condition that has the greatest risk of colon cancer, and it is an increased risk of colon cancer if you have ulcerative colitis. Pain controlled with anesthesia, hopefully within 8 hours, or excuse me, analgesia, not anesthesia, although it would be controlled with anesthesia as well. We want to give them pain medications and make sure that they're working appropriately. The goal is to have it within 8 hours, well controlled, that they're regaining their fluid balance within 36 hours. They have a decreased number of diarrhea bowel movements within the 24 hours. And then long-term goals that they adhere to the regimen, both medications and diet, that they have effective coping mechanisms for the disorder, and that they're prescribed psychotherapy if necessary. Appendicitis, what is it? It's inflammation of the appendix. Something gets caught in there or just has a bad day and decides it's going to act up, right? Right lower quadrant pain is our hallmark sign. Halfway between the umbilicus and the crest of the ilium at McBurney's point. These people may have a low-grade temperature, usually just about a degree raised from the normal rate. What do? We do an appendectomy. We pull it out. That's the only solution for appendicitis, really. We can give them antibiotics and let them keep it, but why? They don't need it. Let's take it out. Third audience response question. The nurse admitting a 23-year-old patient with possible appendicitis should anticipate which signs and symptoms? An increased red blood cell count, abdominal tenderness, anorexia and vomiting, mild fever, or a board-like rigidity. Give me a second to compose your answer. Abdominal tenderness, anorexia and vomiting, and mild fever are correct. Why would they have a rigid abdomen? Well, if they had a belly full of blood, they would have a rigid abdomen. Let's hope that that's not the case with a possible appendicitis. And then we'd see an increased white blood cell count, potentially not an increased red blood cell count. Peritonitis. Well, it's inflammation of the peritoneum, the lining of the abdominal cavity. The peritoneum becomes inflamed. It causes production of serous fluid that becomes infected. It can be fatal. Why? Because it can turn into sepsis, right? The peritoneum is highly vascularized. We've got lots of capillary exchange going on there. And because of that, we can take that infection from the peritoneum into the bloodstream, and therefore all of our major organs may and cause sepsis and multiple organ failure in the works. Bad news. Nausea and vomiting, severe abdominal pain, distension are indicative of peritonitis. We do an H&P, we do a CBC, and we scan for tumors. We want to make sure that it's not something else that's causing this versus just like an infection. If it's an inflammation caused by tumors, then we know that there's a peritonitis caused by tumors as well. What do? Antibiotics. Why? Because this is usually infection. This is infection that comes from the bowels in some way, shape, or form. So we want to treat them with a broad spectrum antibiotic. We give them IV fluids and electrolytes. We may do a gastric or intestinal decompression, typically an NG, drop an NG on these patients. And then surgery, if necessary. Do a washout, right? Malabsorption, irritation of the intestinal mucosa, and consequent diarrhea. People that have celiac disease, lactose intolerance, pancreatic disease, or they have an alteration of the intestinal mucosa that's causing them not to be able to absorb their nutrients, like they're going through chemo and it's killing off the intestinal mucosa, are going to be at risk for this malabsorption. Steatorrhea, or a passage of stool that's bulky, frothy, foul smelling, and usually floats in the toilet. Steatorrhea is fatty stool. Malabsorption, people have steatorrhea. They may experience weight loss, weakness, various signs and symptoms of vitamin deficiencies. How do we treat it? Well, if it's a pancreatic problem, we give them pancreatic enzymes, right? They have to eat them with every meal, take them with every meal. So if we're having them eat 6 meals a day, they're taking it 6 times a day, 3 times a day, if they're doing the 3 meals a day. So ACHS, just like blood sugars, pancreatic enzymes are before meals and at bedtime. Celiac disease, we omit gluten from the diet. Why? Because celiac disease is a gluten intolerance. Lactose intolerance, we limit the intake of lactose. We give them lactase enzyme preparations to help them digest the lactose that they do ingest. And as nurses, we support the patient through the diagnostic process and reinforce teaching about diet medications. Colon cancer. Patients are at risk for colon cancer if they are diagnosed with disorders of the intestinal tract, like ulcerative colitis or polyposis. Other risk factors, if they smoke, they're at an increased risk for colon cancer. If they drink alcohol, if they're physically inactive or sedentary, if they're obese, if they eat a diet that's high in saturated fats or red meats, if they do not take in enough fruits or vegetables. The one food that I want to emphasize with you with colon cancer is anything that's like a processed meat. Processed meats are not good for our bodies, and even though they taste delicious, they can cause colon cancer. So things like bacon or hot dogs, as delicious as they are at a ball game, we want to tell people to avoid them if they can, if they're at an increased risk for colon cancer, like they have a family history or they're already diagnosed with an ulcerative colitis. Okay. Also, any smoked fish or smoked meats are not good for this as well. Signs and symptoms. Well, usually they lose weight. That's the first sign that we see is weight loss. Then they may change their bowel habits. They'll have diarrhea or constipation. There'll be red blood in their stool, or maybe potentially black tarry stool. Sometimes their stool will change. It'll turn ribbon-like. Why? Because they have obstruction, like a tumor in the colon. It's causing it to squeeze out just like in a smaller shape. Abdominal distension without weight gain. just from the growth of the cancer and associated inflammation. Sensation of incomplete evacuation. They always feel like they have to go potty even after they just had bowel movement. And then anemia because of intestinal bleeding. We'll screen them. We'll do a colonoscopy, potentially a transrectal ultrasound, and then we'll test for a carcinoembryonic agent. And oh my gosh, Harley, we'll test for a carcinoembryonic antigen. There we go. Treatment. We'll resect the colon. We'll do a colectomy or hemicolectomy. We'll do abdominal perineal resections. We'll do adjunctive treatments like radiations, chemos, either pre-op, intra-op, or post-operatively. Ostomy surgery and care. Well, this is a colostomy. It's an abdominal incision that's made and then the colon is brought out to the outside to drain out the fecal material. Sometimes these are only for a little while, so they're having something going on, or we need to fix something else, or they've had a major trauma and we've got issues. Sometimes they are permanent. So types of colostomies, there's loop colostomies, double-barreled colostomies, single-barreled or end colostomies. But the first stage of loop transverse colostomy is pictured here. A segment of the transverse colon is brought out through the abdominal wall and it's supported by a bridge. A slit in the bowel allows the feces to drain from the proximal colon, and the support is removed after 5 to 7 days when the bowel adheres to the abdominal wall and has good support just from the body itself forming support for that. Colostomy locations. Ascending colon is where we'll put the ascending colostomies. Transverse colostomies are situated toward the middle of the belly, and then a sigmoid or descending colostomy is usually in the lower quadrant of the abdomen, usually lower left. Types of ostomies and intestinal diversions. If you look here, you've got an ascending colostomy on the upper right quadrant there, a double-barreled colostomy or a transverse colostomy with 2 there in the central stomach, a descending colostomy, lower left, sigmoid, extra low left, and then an ileostomy is going to be, we don't want it to be on the umbilicus or really close to the umbilicus, but we do want it to be somewhere where the patient can reach and provide their own care for. Ileostomy, what does it do? It drains fecal material from the ileum. And what's the ileum? It's the last part of the small intestine. It is indicated when disease or congenital defects or trauma require bypassing the entire colon. So the colon is unusable. The stool is liquid. Why? Because it hasn't had going through the process in the large intestine of water reabsorption. So it's got all that water in it. And it also still contains digestive enzymes, and those are highly irritating to the skin. So if that bowel product leaks from an ileostomy onto the skin, people usually develop a rash or a really bad dermatitis. A pouch ileostomy or a continent ileostomy are 2 different types. And here are pictures of ileoanal reservoirs. Okay. There's the blind end. See where they cut it off. They stitched it together in a loop, and then they opened the end and made the stoma. Okay. The pouch, cock pouch ileostomy. Okay. And then there's a reservoir. So that's your continent ileostomy. Preoperative care, low residue diet for 7 to 10 days before surgery, liquid diet for 24 to 72 hours before surgery. We're going to give these people vitamins and minerals. Why? Because they're not going to be absorbing very many of them. Prophylactic antibiotics, because this is a major surgery. Laxatives and enemas to clean out the intestines so that we can have room to work and visualize. An NG tube or a Miller-Abbott tube to decompress and drain secretions. Nursing management of ostomies. Well, in the immediate post-op care, what are we going to do? Pain management, making sure that we're positioning appropriately, do a psychosocial assessment if they're going to be okay with it, because this is a huge lifestyle change, right? Want to make sure that we assess their psychosocial status and make sure that they have adequate support and coping mechanisms for going home. They need to know how to care for the stoma. So if they see a noticeable lightening or blanching of the stoma, it may it may indicate ischemia. If they have edema or swelling, if they've had decreased fecal output, and so they may have an obstruction or something, and then knowing how to care for their dressing. They need to know all of this. Here is a picture of an ostomy collection appliance. Okay. Care of the stoma. What do they need to do? What do we need to do? We need to measure I&O, evacuate, irrigate if necessary. Cultural issues for ostomy patients. Well, I mean, we have We already talked about psychosocial issues with ostomies. Ostomies are tough. I mean, you've got poop coming out of your body in a hole into a bag, and that can be a little bit disconcerting for certain groups. For example, the Jewish people, for example, don't allow people to use running water or electricity during certain periods of time. And if they're Amish or German Baptist, they may not be able to use electricity or running water. And because of that, they won't be able to do very good hygiene, right? So they need to start if they're having like a celebration, let's say they're Jewish, they're having a celebration that requires them not to use electricity for a period of time or running water for a period of time. They need to make sure that they do all their hygiene beforehand. And if they're a part of a community or a cultural group that doesn't use running water or electricity at all, we need to come up with another way for them to be able to provide hygiene. Okay. So let's think about the Muslims and Ramadan. So a Muslim patient is not going to be eating food or drinking anything between sunrise and sunset for 28 days. So that could be really bad for a patient that has an ileostomy, right? So we need to come up with some kind of care plan for that patient. They may be at risk for dehydration, or just the change can cause severe diarrhea or constipation. So we need to make sure that we've got some kind of a plan for them going home. So around the skin, or excuse me, around the stoma, we want to be able to take care of that skin. We need to make sure that it's clean and that there's always a protective barrier, and teach them how to change their collection device and when to change it. And then just again, psychosocial concerns. Something to think about. Hemorrhoids. Hemorrhoids are varicosities of the veins of the rectum due to venous congestion. They can be internal or external, so you can see them or not see them. They can be caused by constipation, being overweight, standing a lot, sitting a lot, or being pregnant. Pregnancy does it too. Signs and symptoms: rectal pain and itching, rectal bleeding if one starts to pop. What do? We apply either heat or cold. We can do sitz baths. We can apply like a hemorrhoid cream with hydrocortisone and a little a local anesthetic. And then we can also do surgery and do a hemorrhoidectomy if it's really bad or really bothersome. Pilonidal sinus, which is a pilonidal cyst. These can get infected if stool gets in them, or some kind of bacteria starts to grow in there. It's a lesion located in the cleft of the buttocks, usually just right underneath the coccyx and above the anus. It's believed to be a subcutaneous canal or sinus with one or more openings into the skin. If they would not have closed, they would have been they would have had an opening there, a larger opening there. No symptoms until it becomes infected, because usually these patients are asymptomatic if they have one. Lots of babies have them. It's actually kind of like one of those normal, abnormal findings. So yeah, I mean, it happens. But then when it does become infected, there's pain and swelling and purulent drainage. So just it's not comfortable, usually really red and swollen, and they can't sit down. So they can't drive. When we do the surgery, we have them laying on their belly, of course, so we can access it. But also in pre-op, they might kind of lay on their belly or their side just so that they're not putting pressure on it. We'll do an I&D for these patients, cut it open, drain it out, put in some packing maybe. And post-op, we'll take out the packing, we'll cleanse it with warm water. We'll encourage them to cleanse it with warm water anyway. And then we'll redress the wound. Okay. They'll probably want to stay off of it for a little while to promote healing. Anorectal abscess and fistula. Well, an abscess is a localized infection with a collection of pus, and a fistula is a chronic granulomatous, I tried, guys, tract that travels in a line from the anal canal to the skin. So, no fun, right? Anorectal fistula. Discharge of pus comes from the fistula. It can be very painful. We give these patients pain medications. We may do an incision and drainage or a repair of it. We need to teach them how to prevent constipation and also infection, and then how to make sure that they keep their rectum nice and clean, their anus nice and clean. Sitz baths will help decrease inflammation with these patients. And that's the end of the presentation. I know that we talked about fistulas before, like abdominal fistulas that come from the intestines, usually related to cancer. So if you guys have any questions about the chapter 29 content, just let me know. Have a great night.